Welcome to this episode of Psoriasis Uncovered, a podcast series produced by the National Psoriasis Foundation, the nation's leading organization for individuals living with psoriasis and psoriatic arthritis. Join us to hear our guest speakers uncover topics that lead to a better understanding of the disease and management, to coping and thriving with psoriasis and psoriatic arthritis.
My name is Archie Franklin, and I'll be your moderator for today's discussion about the latest position statement from the Medical Board of the National Psoriasis Foundation and the International Psoriasis Council about routine testing for latent tuberculosis infection prior to and during treatment with psoriasis with IL-17 and IL-23 inhibitors. Joining me for this discussion will be Dr. G. Scott Drew, who is a dermatologist from Mid-Ohio Dermatology Associates and a member of the NPF's Medical Board, who participated in joint development of this position statement. Welcome, Dr. Drew. It's a pleasure having you on Psoriasis Uncovered to discuss the latest position paper. Let's start with some basic questions before we discuss the change this position paper represents. Can you explain what is tuberculosis or TB, and why is testing required with the use of TNF inhibitors like Enbrel, Humira, or Remicade?
Thanks, Archie, for having me. Those are all great questions because there's so much evolution going on in the understanding of the science of more of our advanced therapies in psoriasis and psoriatic arthritis. So we know that tuberculosis, which is an atypical mycobacteria infection, infects a lot of people, many more in indigenous areas like sub-Saharan Africa and South America, less so in the US, but certainly in populations where people live close together, prisons, nursing home, group homes, and then in certain endemic areas of the United States, we also see TB. And the problem can become, we can become drug resistant to tuberculosis, and it can be very difficult to treat and often requires multiple antibiotics to control the disease, like rifampin and ethambutol and INH, and sometimes quadruple ripe therapy. And so we get concerned because TB, once you have it, can become latent in your body, and it can sort of become dormant, like hibernate, if you will, if I can extend that metaphor a bit. And it hibernates instead of in caves like bears, it hibernates in a ball. We call it a granuloma. And that granuloma is held together by glue, if you will, and that glue is maintained by TNF alpha, tumor necrosis factor alpha. If you don't have TNF alpha, that granuloma can break up and the TB can become not latent but active, and it can reactivate. And what's interesting about tuberculosis and skin, 98% of the world's TB happens on the skin, and 2% are extrapulmonary, other parts of the body, brain, heart. But in reactivated latent TB, 60% of it, 60 is on the skin. So why is this important for our conversations? That's because we have a class of drugs, anti-TNF alphas, which TNF alpha also is active in the whole psoriatic disease cascade. If you block TNF alpha, which helps the psoriasis and the psoriatic arthritis, as well as other diseases like rheumatoid arthritis, it can cause that granuloma of latent TB to break down because we need the TNF alpha to keep that granuloma intact. And if we get rid of the TNF alpha by drugs like Humira or Cimzia or Remicade, infliximab, the granuloma breaks down and you get reactivated tuberculosis. So, the adage, do no harm. If you give someone a drug like the ones I mentioned, you have to make sure that they don't reactivate their TB, and we do TB testing on them to make sure we don't put them at risk of developing TB. We don't want the cure to be worse than the disease because TB can be highly contagious.
Very interesting and a great explanation of that. What is the frequency of TB testing, and are false positive tests ever a result or a concern?
You've done your homework. These are great questions. So we do testing currently. I think every biologic and even a few small molecules and peptides have labels that say evaluate for TB. It's particularly germane in the TNF alpha world because, again, as I said, if you block TNF alpha, you run the risk of increasing tuberculosis reactivation. So we do that prior to initiation or until recently, on all biologics and many, many small molecules. But only TNF alphas play a role in that, not so much IL-23s or IL-17, some of the newer biologics. So typically we would test once a year, and again prior to therapy or at the onset of any symptoms, relapsing fevers or night sweats, weight loss or coughing blood, etc., would all obviously generate another test. And Archie, you hit it right on the head. False positives are a big deal. I mean, sometimes stuff happens with labs and all sorts of things. But if you get a false positive and you put someone on a ripe therapy, you introduce people to drugs that are not innocuous. You put someone on ethambutol and isoniazid, rifampin, they're going to lose weight. They're going to have diarrhea, not just diarrhea, but like anal leakage style diarrhea. These are drugs that are causing quite a bit of morbidity, if not mortality, because of the severity of these diseases. So the other thing to consider is sometimes our psoriatic disease patients are generally not as well as some of our atopic patients or skin cancer patients or our acne patients. And if you introduce a drug that has so many comorbidities associated with it, you really put the patient's life and limb in jeopardy because of a potential of a false positive.
I could see that could be a real challenge with, as you mentioned, the different kinds of medications that are available. Are there other immunosuppressants that maybe are still used in treating of psoriasis, psoriatic arthritis, where there's TB testing, or is it just with the TNF alphas?
We're in the day and age now where we are out of the sort of, let me just generally immunosuppress you to make your psoriasis go away. We're now in the marriage of mechanism of disease married to the mechanism of action of the drug. So we actually have a very targeted approach to making the psoriasis better. So instead of just blindly suppressing the immune system, we can say, you have too much IL-23. Let's block that. You have too much IL-17. Let's block that. So I think we're moving away from drugs that are just sort of general things like methotrexate, Imuran, cyclosporin. Now, I'm not saying we never use those because sometimes we can get people to, PASI 85 or 90, and we're just not, we need something to get them to a PASI 100. But I think we're moving past the era when we have this relatively older model of disease modification because the NPF, which is just such a great organization in terms of research and advocacy and education, we now can expect people to be 99% cure 99% of the time within 90 days of treatment. And those are numbers that when I was a resident in a different century, they were just numbers we'd only fantasize about. And now when we see a patient, they come to us and they've been told they're too fat or they're too lazy or they're too dirty and it's just psoriasis. It's just your skin. Don't worry about it. We can now tell these people, you're not a psoriatic. You are a human being with aspirations and dreams and life and passions who happens to have psoriasis, and we can make you better with drugs that are far safer and far more efficacious than I trained with back in the 80s.
Certainly, I can understand that because as someone who is 100% clear, it's been a life-changing for me. But as we analyze and talk more about TB testing, is there a consequence to too much or unnecessary testing? And does TB testing create a barrier for psoriasis patients as far as accessing treatment, in your opinion?
So first off, nobody wants extra blood tests. We already discussed false positives. That's clearly an issue. And I have to be quite candid with you, Archie. I think in the mid or the first quarter of the 21st century, our friends from the insurance company use testing as an obstacle to access to drugs. And it creates one more barrier that keeps people accessing the drugs that they deserve to have access to. So that's a problem. Now, having said that, our psoriatic disease patients, again, as I sort of mentioned, tend to be a little sicker. So at some point during their psoriatic therapy, they deserve to have their glucose, their lipids, their serum insulin evaluated for things like metabolic syndrome and obesity to get their whole body where it needs to be. But generalized screening for tuberculosis in the absence of other comorbidities doesn't make any biologic, pathophysiologic sense because we know that IL-23s and IL-17s, whether it's 17A or 17AF, does not interact with a pathway of tuberculosis reactivation. So that is why testing can really just be an obstacle because in the prior iteration, we would say as soon as your tests are negative, we're going to start your therapy. But Archie, you and I both know that the walkaway rate from blood tests is about 22%. And when you hand someone a slip and they leave your office to go get a blood test, well, their life is busy. The slip ends up in the back seat or it ends up in the bird cage, and they end up not getting access to therapy. So now, if you're not using a TNF alpha, if you're using a 2.0 version of a biologic, if you will, that metaphor, you can safely get a sample or get your medication fulfilled through your pharmacy and not have to get that testing done. And it speeds people's return to the quality of life that they deserve. Well, you know, Archie, with yourself, because you know, people who have psoriasis, they don't go to the gym, they don't wear short pants, they don't go to Massage Envy, they don't get manis pedis, they don't play pickleball in shorts because they're embarrassed. Their joints hurt. And I'm sure our listeners know the quality of life diminution that occurs because of the psoriatic disease state. And whatever obstacles we can eliminate or ease or lower helps people get access to the care that they deserve.
And I think you've been able to kind of describe that as far as access and medications, how the TNF alpha inhibitors versus the IL-17 inhibitors and the IL-23s, how they don't have that concern for latent tuberculosis reactivation due to the granulomas and how the TNF reactivates that. And I really appreciate you helping us getting an understanding between the different biologics and the difference and how it's relevant to development of the joint statement from the National Psoriasis Foundation's Medical Board and the International Psoriasis Council on routine testing for latent tuberculosis infection prior to and during treatment of psoriasis patients with IL-17 and IL-23 inhibitors. So the question then becomes, what are the primary recommendations that are supported through this position statement? And why did the NPF and the IPC jointly develop this statement?
What a great topic. There was a consortium between the IPC, which is the International Psoriasis Council. It's a group of psoriatic experts around the world. And the NPF is a group of psoriatic experts in the US, which I'm proud to be a member of that medical board. And there was confusion about the current state of affairs. And we wanted to be able to provide guidelines, not just for our providers and our patients, but also our third party reimbursers so they could understand the latest science. I mean, let's face it, we're all lifelong learners. And that's why we have journals that come out. Oh my God, I get a journal every day. It's hard to keep up with everything. So we decided on these two different bodies, of which there's some overlap, how to best educate our stakeholders. And so a lot of people got together for these joint statements. And to get this many people together agreeing is pretty impressive. And we had 87% consensus on the lack of a need for TB testing in anti-17As, anti-17Fs, and anti-23s, and only reserving them for anti-TNF alphas. So you say, why only 87%? And I'll tell you, a few people were concerned about indigenous populations. As I mentioned earlier, prison populations, nursing home populations, group homes, and areas like southeastern United States where tuberculosis is indigenous. So let me just make sure I clarify. TB testing is not prohibited in other drug categories, but it is not necessitated. So if you have a patient who's got psoriasis, who you believe has an indigenous risk to tuberculosis, well, they should be tested. No question about it. If you have someone who's got psoriasis and they're coughing and they're hacking and they're losing weight and they're having night sweats and their chest x-ray is positive, well, yes, of course. But the patient without risk factors who's on a 17A, 17AF, or 23, the NPF and IPC international accepted guidelines no longer require screening before the initiation of therapy. Patients come into you and you're their third, fourth, or fifth dermatologist, and they're on creams and they're on steroids and they're on prednisone or methotrexate. You no longer have to say, go home, we'll get a blood test, we'll wait for the results, and then we'll see you. We can say, no, we're going to start you today. I have a sample in my closet. I'm going to give you a medicine. I'm going to give you a shot. And when I see you back in a month and your drug is approved, they'll already be better. They'll already achieve PASI 50, 60, 75, 80, 90. Some of these newer 17AFs, they have PASI 90, PASI 100 data at week 4. And we're talking about patients who have not worn short pants for decades. people who don't go on cruises because they're embarrassed about the way their knees and shins look, people who would never wear sandals because they're embarrassed about their toenails because they have nail psoriasis, people who don't go to the beauty shop because they're so encumbered by the quality of life diminution of their scalp psoriasis, or marital intimacy is diminished because of the stigma of genital psoriasis. So this elimination of the requirement of a test, particularly for offices that don't draw blood in their office. This is really a revolutionary step forward to easing the access to drugs that now patients can have, and we can concentrate our efforts on access instead of obstacles of blood testing or even time testing or whatever method you're going to use for tuberculosis.
So what I'm hearing is that as far as your current approach right now is you will provide the patient an immediate access to a sample of these biologics. And basically, as long as this patient is not in one of those indigenous type of group settings, they can get started on their medication right away. That's terrific. I've been involved in clinical studies, and certainly there is that wait time and getting between the test and the start. And yes, there are some challenges there. And it sounds great that you definitely counseling your patients that it's time to get started immediately.
Archie, to borrow your phraseology, the wait is over.
Oh,
You
I love
can
that.
start your therapy right away and without fear. And I think, and quite frankly, the IPC and the NPF are motivated to help change labels. And currently, the label says evaluate for TB. And I interpret that, I kind of follow the science. We know about this TB granuloma maintenance by TNF. So I have not routinely done TB testing on 23s and 17s for years. So when I see a label that says evaluate for TB, my evaluation is, are you having night sweats? Are you coughing blood? Are you having a recalcitrant cough? Do you have relapsing fever at night? And Archie, if I saw someone like you walk into my office, healthy, robust, asymptomatic, no risk factors, I'm not going to say to you, Archie, I'm going to wait 4 or 6 weeks for you to get yourself over to the lab, get your blood drawn. And when that's all done, then we'll worry about your quality of life. We don't have to do that. Now, again, I want to reiterate, I think we have a higher risk of a psoriasis patient compared to your regular non-psoriatic patients, do have some other comorbid risks that are cardiovascular and metabolic that are worthy of other blood tests. So we have to, we're doctors first and then we're dermatologists, right? I think it's important we take a very holistic approach to their health. And I think we need to remember that we now have the opportunity to promise people improvement with their psoriatic disease. And we have to remember the psychic health changes that are associated with the psoriasis, not just the diabetes and hyperlipidemia, but depression, anxiety, loss of work. If you're an adolescent or a kid with psoriasis, you know what school is like.
Right.
Oh my God, we can't have Billy on our team. Billy's got cooties.
Very challenging
So
for sure.
all these things that fit into the broader picture really relieves our patients of our psoriasis burden. And Archie, we always talk about quality of life, and that is a critical component of our dermatology world. When we take care of a psoriasis patient and we walk into the room on their 4-week follow-up, and you can just look in their eye and know how happy they are. I go home from work thinking, someone's happy I'm above ground. It is a good day when you know you've helped somebody. And that's why we all do what we do, right?
I couldn't say it any better. So as we talk about other targeted treatments like JAK inhibitors or PD4 inhibitors, and the new oral agent, the Icotide, what's the TB recommendations amongst those groups of medications?
So, Icotide just came out and
Mm-hmm.
there's no label for TB testing. So that's pretty exciting. And that's a oral peptide, which is an IL-23. So you don't need any TB testing for that. And apremilast, which is a PD4 inhibitor, also does not have a label for TB testing. Now, the JAK, that's a different story. I think it's still prudent because there are some select cases there. But again, currently, to my knowledge, there aren't any JAKs that are in widespread use on label for psoriatic management. Now, I think that the future is still the future, but in current use, I think that's where we are.
So it's obvious you see a lot of great benefits with this position statement. As someone who's participated in multiple clinical trials for biologics, what do you think the implication of this particular position statement will mean for the future of clinical trials?
Well, I think it will ease people's mind when they're prescribing them, but it also will make patients more eager to do it because as soon as you say, I'm going to make sure you don't have TB, my analogy to my students and residents is it's kind of like saying, don't worry, there's no fire on the fourth floor of the skyscraper. And people are like, what's wrong with the fourth floor? I'm not going there. So you're creating this false sense of disease susceptibility when you even say that. Well, why are you testing? So it makes the patient less worried about something that they're really at no risk for. So sometimes I think if we order these tests unnecessarily, it makes the patient nervous. And when we talk about drugs like adalimumab, cerulizumab, and infliximab, which do cause a small degree of immunosuppression. Now, having said that, they're far safer than methotrexate. I mean, let's be honest. I'm of an era where we did liver biopsies on. No, I didn't do them.
Right.
I ordered plenty of liver biopsies in my day when we had to count the amount of drug that a patient ingested before they got to 3.5 to 4 grams of cumulative therapy. Those days are gone. And these new agents we have, even the TNF alphas, are far safer and far more efficacious than what we've had when we were younger.
And certainly as someone who is of the age where I've been on methotrexate and had to get other testing, it sounds wonderful that anytime we can reduce testing around these new and improved therapies, it's really great. I want to say thank you, Dr. Drew, for being part of the efforts to develop this position statement and for being here today to discuss what the changes in TB requirements means for psoriatic disease community. We are grateful for your participation as an NPF Medical Board member, and we are very appreciative of the IPC partnership and its important position statement. Do you have any final comments you'd like to share with our listeners today?
Yeah, I sure do. Hey, thank you, Archie, for taking your time as well to bring this to the table.
You're
The
quite
NPF
welcome.
is an incredible organization. It really is the leader in dermatology advocacy for patients and research generation and dissemination of state-of-the-art current medicine from reputable sources. And I encourage everyone to become a member and to go on their website and advocate for them in your office. They have enormous resources and printed and online materials, and they make my practice better every day. So thanks to them. And good luck to all of our providers out there who continue to learn and serve their patients and make their lives better in the fight against psoriatic disease.
Thank you, Dr. Drew, for your closing comments. It's so important to have discussions like this on Psoriasis Uncovered. For our listeners, if you still have questions, contact our Patient Navigation Center at education@psoriasis.org or download information about treatment options at psoriasis.org/resource-library. Finally, thank you for listening to Psoriasis Uncovered, where we uncover what you need to know about psoriasis and psoriatic arthritis.
We hope you enjoyed this episode of Psoriasis Uncovered for people living with psoriasis and psoriatic arthritis. If you or someone you love has ever struggled with psoriatic disease, our hope is that through our podcast you'll gain information that inspires you to lead a healthy life and look to the future. Please share the episode link if the content in today's episode will benefit someone you know. You can find this or all future episodes of Psoriasis Uncovered on Apple Podcast, Spotify, Amazon Music, Ghana, Pandora, iHeartRadio, and the National Psoriasis Foundation webpage. To learn more about this topic or others, please visit psoriasis.org or contact us with your questions or comments by email at podcast@psoriasis.org.